Can I have my slides? Okay. Thank you very much. Thank you, Society, for inviting me to work with you here. I'm very, very excited after 3 years because of COVID-19. Finally, it becomes true for this trip. It was very tough when I got to pass through the airport and the fast train station. Oh, thank you. Okay. So the topic of my presentation is the best strategy for left main bifurcation lesions. I have nothing to disclose. So actually, for any given two bifurcation lesions, particularly for distal left main bifurcation lesions, which are identical. For example, the left case shows a simple distal left main bifurcation lesion. Right one is a complex bifurcation lesion. Why the right one is a complex bifurcation lesion? Because the disease in surface is very diffuse. So this is the key components to define the complex bifurcation lesion. Actually, in terms of the distal left main bifurcation lesion, there are many, many factors of determining the short-term and long-term clinical outcomes. For example, vessel lesion length, vessel diameter, bifurcation angle, and also the presence of calcification. Also, most of patients with distal left main bifurcation lesion have the triple vessel disease, reduced cardiac function, and also most of patients presented ACS. Also, there are high frequency of comorbidities, for example, diabetes. So from the beginning of the standing technique for distal left main lesion, the compressing of upfront two-stand technique with provisional stand technique is a hot topic. So similar to the negotiation between China and United States about many, many issues, that too. And according to the Medina classification, all distal left main bifurcation lesion could be classified according to the presence or absence of the lesion as the osteolarity, symphysis, or distal left main. It will be classified by just distal. It means no lesion involving in the osteolarity or symphysis. To Medina 110, it means no lesion as the osteosymphysis. To the final true bifurcation lesion, Medina 111 or 011. So for the led two kinds of true coronary bifurcation lesion. Actually, two-stand technique is frequently required from any randomized study. So let's go back to a few years ago, Excel trial comparing PCI and KBG for left main disease, but not only for left main bifurcation lesion. After 5 years of follow-up, so the final result favoring the one-stand strategy compared to two-stand technique. But what should be kept in mind, because this is not only for distal left main bifurcation lesion, for overall bifurcation lesion. So in the subgroup analysis for distal left main true coronary bifurcation lesion, so the provisional standing technique with one stand is superior to provisional with two-stand technique or any other kind of upfront two-stand technique. Again, last year, EBC main trial was published in European Heart Journal. So after 1 year follow-up, they got the neutral result because most of the lesions included in this trial are very simple. For example, side branch lesion length shows an 8 mm. Syntax score was around 23, which is very, very low compared to our previous studies. So back to the 2018 ESC guidelines recommend if a side branch diameter minimum 2.75 mm, side branch lesion length greater than 5 mm, or operator feels that it will be very tough after standing main vessel to touch a side branch. So this criteria were built only according to one small European study, including only 120 patients. So I think there are some limitations for this criteria to differentiate simple from complex bifurcation lesion. So almost 9 years ago, we merged several Chinese databases together. We tried to establish a criteria. So nowadays it's called definition criteria from 1,550 patients with true coronary bifurcation lesion. So the major criteria included side branching lesion length minimum 10 millimeters for left main or non-left main bifurcation lesion. But the baseline side branch diameter stenosis could be 90% for distal left main or 90% for non-left main bifurcation lesion. Also, we provide 6 minor criteria, for example, greater than mild calcification, multiple lesion, bifurcation angle, small or too wide. Also, main vessel reference vessel diameter less than, small than 2.5 millimeters, main vessel lesion length greater than 25 millimeters, or thrombus containing lesion. So any one major criteria plus any 2 minor criteria, so lesion could be classified by complex bifurcation lesion. So again, we testified our definition criteria in another external group, including of 3,660 bifurcation lesions. After that, we designed this definition 2 trial. It was conducted at 49 international centers, including 660 patients, were randomized to provision with systematic two-stent technique. The primary endpoint was a 1-year target lesion failure. Stent thrombosis was a safety endpoint at 1-year follow-up. So this figure shows the 1-year result. So you can see in provisional group, there was a very high rate of tight lesion, revascularization, tight vessel mark, cardiac infarction, finally leading to very high rate of 1-year primary endpoint. It was 11.4% compared to only 6.1% after two-stent technique. In this study, in the systematic two-stent group, almost 80 to 82% of the lesions were treated by decay quatch. So here I could boldly say decay quatch is superior to provisional stenting technique for real complex bifurcation lesion. After 1-year report, last month, our 3-year follow-up was just published in JACC Cardiovascular Intervention. From the figure, you can see from left to right, as 3-year follow-up, the difference in terms of the primary endpoint between provisional and two-stent technique was sustained for 3 years. On the right figure, you can see the increase of tight lesion revascularization in provisional group increased much more compared to decay quatch technique. To be honest, after 1-year follow-up, there was further increase of TAR in provisional group with very flattened, very straight line in the two-stent group. Also, we performed subgroup analysis in a Q-lot group compared to decay quatch group. So this finding was very similar to Nordic trial, which reported very high rate of stent thrombosis after 5 years of follow-up after Q-lot stenting technique compared to classic quatch technique. So even so far, there was no consensus data to support which stent technique is best for distal left main. But I do believe, I do trust decay quatch is the better one for distal left main complex bifurcation lesion. So let's get back to the subgroup analysis from our decay quatch 5 study. So right panel is a complex subgroup, left one is simple complex simple subgroup. So similarly, EBC main got very similar result to our simple subgroup analysis. So in conclusion, definition criteria identified the complex bifurcation lesion. So the systematic two-stent technique, particularly decay quatch, is associated with low rate of clinical events, including tight vessel mark, cardiac infarction, TAR, as well as stent thrombosis. Also, I'd like to say there are more similarity than difference between EBC main and our decay quatch series trial, particularly decay quatch 5 trial, because most of simple lesions included in the EBC main compared to decay quatch 5. Finally, I also like to say most of distal left main lesions in Asia countries are pretty complex compared to the left main lesion included in the study based on from European trial. I think we still need more clinical trial to provide very solid evidence with our international community. Thanks for your attention. Thank you very much.
very convincing data for DK Crush. I think he's the biggest supporter for DK Crush, perhaps internationally. And now it's my pleasure to invite our teacher and friend and a co-director of this course, Dr. Rosli M Ali, to speak on treatment dilemmas in interventional cardiology, the challenge of using DCB in clinical practice. He is perhaps one of the biggest advocates of DCBs.
Assalamu alaikum and good morning, ladies and gentlemen. It's great to be back in Pakistan to meet with friends. And Nadim, meeting in Paris does not really count. Can I have the slides, please? Yes, DCB is used quite frequently over in Malaysia and in Southeast Asia. So, can I have slides? Yeah. Right. All right, thank you very much. Okay. We have had our hands on DCB for a long time. In fact, the first global launch was in Malaysia in 2008. And we also were involved in the first trial involving de novo lesions in patients who are diabetic, and this was the PEPCAT-4 trial. I think one should realize that the importance, or rather the advantages of DCB, and essentially DCB is leaving nothing behind. So when you have leaving nothing behind, in-stent thrombosis is less because there's no stent struts, and you can even think about giving a much shorter duration of DAPT. Now the question is that, when we were having our DS, and this is a patient very early on in July, diabetic, we were stenting it and with 2 long ciphers, and it was not indicated at that point in time, but we were pushing the boundaries even from the very beginning. And you know that when you have lesions like this, when the results, CTOs and long lesion, and this is something that you want to try to avoid. And this is where DCB would be one of the alternatives in terms of treatment. Now, one of the common issues or challenges is that people will say there is no strong evidence to use DCB. I believe that the strongest evidence is really with the use of DCB in in-stent restenosis. It is comparable to DS, less risk of TLR and also MACE. And of course, we will not want to consider or think about putting a second layer of stent struts in a lesion. So we try as much as possible with DCB. But DCB, and this is a case that I showed you just now, and this was treated with DCB, and after DCB and followed up about 63 months or 67 months later, she came back with angina, and this time the lesion was only a focal lesion in the proximal LED. So this is something that shows you that if it's used properly, the chances of it lasting long is very good. So ISR, no questions about it. We have data now for small vessels, comparing vessels of 2.75 and smaller with the DES, and it's comparable at 1 year, and when it was carried on to 3 years, it was still similar. Bruno Scheller actually also did a meta-analysis, and this is very interesting because this is for the first time in a meta-analysis, of course, that the survival is actually better when the lesions are treated with DCB as compared to patients who are lesions who are treated with either POBA, DS, or BMS. So at least for the first time, it showed advantages in terms of survival, or even in terms of cardiac death is reduced. Okay. So the one thing that I'm very keen in DCB is that you can actually find that in 70% of patients you treat, if you treat them well, you can have an enlargement of lumen, and this is due to vessel enlargement. And this is, the vessel heals and vessel enlarge, and the vessel has got normal function. Unlike a stent, when you put in a stent, the lesion is caged, the vessel is caged, it cannot grow anymore. So that's one of the advantages or the benefits of using DCB. These are the clear indications, DCB, ISR, small vessels. And the question is, what about de novo? And this is de novo, as you know, is where the money is. This is where the most cases or lesions that we treat, especially in 3.0 and above. Stent data is very strong, and the data for DCB is not as robust. So we need to actually do some work with regards to this group of patients. Now, this is other main limitations, the cost. Nadim always tells me cost is more expensive than DS. Yes, it is an issue there. And then it takes a much longer time. And I tend to agree, because here you are, you don't put in the stand. You're treating it like the old days of POBA. You've just got to be patient and you've got to wait for a longer, much longer period of time. Yes, those are issues. And the question is about issues of dissection. We are so used, when you have C dissection, stent it. And always people are saying, you don't want to be, at night, you are woken up saying patient has got abrupt closure, isn't it? It doesn't really work that way, but these are the issues. So the question is, which are the dissections that you can accept? Those are important considerations, and this takes a lot of experience and confidence. Now, for example, this is a case that was done, had multiple procedures in the past, familial dyslipidemia, hypercholesterolemia, and coming with a proximal LED lesion. This was treated, prepared, and then treated with DCB, and you can now see that that's the results after. There's some dissection over, and you can see some contrast staining. This, I would not fault if anyone says that they want to stent this, but in this current period of time, we would say that if the flow is all right, you do not have to stent this. You accept these results. And this is after waiting about 30 minutes. And if you have flow, good flow, after 30 minutes, you will know that this is going to be, it's not going to close. And that's the results. After the post results, we managed to bring the patient back for restudy, and you can see that the vessel still remains the same. It has healed, and the flow is good. And that's just to show that, again, the confidence of knowing which dissection to be concerned about and which you can leave behind. Okay, so this is the current guidelines, and the guidelines suggest that optimal vessel preparation is key. It's very important. So you need to prepare the vessel very well. And once you have acceptable results, in this case, less than 30% residual stenosis, dissection, if it happens, it is non-flow limiting. If you use an FFR, then it has to more than 0.8. If you have this, you can be confident of trying to put in a DCB. Otherwise, use a DS. Now, the optimal vessel preparation, and this is a concept for DCB, it is only to deliver the drug. It's not to relieve the stenosis. So again, vessel preparation is key. Once you have a successful DCB treatment, then you will be able to place in the DCB. So these are two important concepts, vessel preparation. This is a young gentleman who had a recent MI and occlusion of the LED, a diagonal 1 and a diagonal 2, which is disease. And this was treated with pre-dilatation with POBA and subsequently a cutting balloon. That's the results after the cutting balloon. So result looks quite good. So I said that we can try to use DCB in this case. It was these two DCBs, 3.0 and 3.5 in a de novo lesion. We also treated and prepared the diagonal 1 and the diagonal 2 and treated that with DCB. And that was the results after. So you can see that there's some dissection seen. And you will see that it's most times than not, you want to stent this, but the flow is still good, and we decided to leave this alone. And we managed to bring this back again about 16 months down the line, and the vessel has healed, and the flow is quite good. Okay. All right, so this is 16 months restudy, and as compared to the post-index procedure, we showed that there's dissection, and dissection has healed, and the vessel has actually grown. All right, so I believe that the indications for use of DCB, ISR, I think there's no query about it because it's provided by guidelines, and and the data is strong in that, and you don't want to put a second stent. But this is where I feel that we are going to go ahead. I feel that it's more likely we're going to use a hybrid procedure. It means to say that there are certain lesions that we try not to want to stent, for example, long lesions, distal, small vessels, and you want to try to avoid stenting as much as possible. And perhaps the proximal lesions, when there's a dissection which is non-flow, which is flow limiting, then you want to put a stent in because the data is very strong. I never put a DCB for left main unless it's for instant restenosis. So, before that, I think for potential for a full DCB, it depends on the vessel preparation. So vessel preparation is key. If you get good results, as in the last case I showed you, then you want to consider DCB. Obviously, it takes a lot of commitment and a lot of conviction that it works for you to want to use it. So if you have to look at our statistics, these are the majority of hospitals in Malaysia, in the government hospitals, some of the private hospitals, you find that DCB use has increased over the time. It's about 17% the last count. And even for our own institution, we are a private institution, fairly small, and we only do about 800 PCIs per year. You find that 50% of patients would have a DCB either as treatment with hybrid treatment or a small proportion using just DCB alone. So in conclusion, ladies and gentlemen, I want to show you that DCB treatment is a good alternative. Obviously, it cannot replace stenting. And what is key is the optimal vessel preparation. You have to, the important thing is to gain confidence that it works. You just have to change in practice. You have got to be patient. You believe that you want to leave nothing behind, then patience is key. And then, of course, as I said, optimal vessel preparation, because you need to not be afraid of all dissections, and you need to make sure that you do not try to convert to stenting, because once you convert to stenting in a significant number of times, then your confidence about this technique goes away. So it is very important to try to do it well, and so leaving nothing behind to me is key, and I'd like to invite you to Asia PSR in October. Thank you very much.
Thank you very much, Dr. Rosli, for staying on time. I'm sorry we are running a little bit behind, but we'll definitely catch up in next session. So now we are going to do basically based on the same theme, we decided that we will be requesting some of our colleagues from Pakistan to present kind of a osteolarity and circle liens and have a discussion on those cases, and then later on see how they did it. So first I'm going to request Dr. Amir Hussain Bandeshah. He's going to present the case of isolated osteolarity lien. And I would request to basically stay on time. There will be within 5 minutes, there will be a brief presentation. Then we will have the panel discussion, and then he will show us how did he do it.
Hello.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm going to present a case of osteolarity. How did I do it, and what are the pitfalls and positives in this case? And my patient is 55 years old male. He belongs to middle class family. He presented with chest pain for last 1 month, angina class 2, and nowadays the chest pain is increasing in tempo, and the patient landed in emergency with the significant chest pain for last 2 days. He is smoker and hypertensive. There is no significant risk factor. The patient was stable hemodynamically, and his ECG showed there was loss of R wave from V1 to V2, biphasic T waves from V1 to V4, and blood test basically showed the troponin levels, they were significantly raised up till 7 times, and hemoglobin was normal, random blood sugar was normal, renal profile was normal. His echocardiogram showed there was moderate anterior anterolateral distal half of apex and apical and distal half of septal hypokinesia, and the EF was around 40 to 45%. His angiogram was done. Left main is normal bifurcating. If you see very keenly, there is mild tapering of distal left main. Ostium of the circumflex shows mild disease in the ostium, but definitely in the next slides we will see in the IVUS whether there is disease significant in the ostium or not. And LED, there is a subtotal LED, more than 90% of the stenosis, and distal LED shows TIMI2 antegrade flow, and the mid part of LED is also diseased. Moderate disease is there, which was also later confirmed on the IVUS. The right vessel was dominant, and there was mild disease in the right, and proximal part of the vessel, then the distal flow in the right is also normal. Medina classification for osteolarity, to me, angiographically it was 0, 1, 0, and the syntax score was calculated, it came to be 14. And before I jump to the case, how did I do it, I would like to highlight few slides that how I planned this case. Basically, this is all theoretical discussion. Osteolian. Okay, this is Medina classification. Points of concern, if you allow me just 2 slides, I will like to discuss with my other operators. We should concentrate on hemodynamic stability. Bifurcation angle, already it is discussed with all of the hall, but with the prior operators and prior people who delivered the lecture. Presence of significant distal left main disease, presence of significant osteal circumflex disease. The IVUS is very important in osteal liens. It is used to rule out disease in the osteal circumflex, distal left main, the morphology of the plaque, and lien of the length as well as morphology of the length. Excessive stent movement is the main concern in the osteal nailing or the osteal placement of the stent, and geographical miss and stent into the left main. It can be, in case we do, there can be hanging into the left main. Carina or the plaque shift in the ostium can be, and the dissection of the left main should also be considered and kept in mind while you are doing this case. Strategies of the osteal LD stenting, there are different strategies. We can have nail in the ostium, which is conventional. There is Zabo technique, crossover technique, balloon in the side branch, IVUS guided osteal placement, it's also called aggregate technique, or the rapid ventricular pacing for the placement of the stent. In order to avoid excessive motion, we can use a larger guide, 7 French or more, 7 French, maximum 7 French for the radial, and if you want to go up to 8, you will need to go from the femoral. Angiographic selection of the view is the important caudal, RAO, or the LAO. We can zoom the image, we can simultaneously place side branch, we can place one balloon. Respiratory motion can be controlled with the gentle shallow breath, and cardiac motion can also be theoretically, but it is never done by me, at least practically. How did I do it?
Let's have a quick discussion for 5 minutes from the panelists and ask how would they do it, and then we can discuss. So, Dr. Afsar Raza, if I ask you, like, what would you do in this case? Would you consider just osteal nailing or come into the left main, or how would you proceed?
I think this is important that we do the imaging of left main and see if there is any plaque burden in the distal LAD or ostium of the circumflex. So that is one thing. If imaging is not available, I think with gross eyeballing, then we have to, if there is a foothold, then you can do the osteal nailing. But I would probably say that in this such case, it is important to have the IVUS imaging. And with regards to the this movement of stents ostium when we deploy, another technique is to put a wire in the second wire in the aortic root. And that can stop the movement of stent. I don't know the experience of others.
Okay, Nadeem, can you?
There's not much mismatch in the left main and the LAD. Then I would just go ahead and do a crossover stent, because IVUS is only available in less than 5% of the cath labs. So we have to be practical. So if there's not much if there's a lot of mismatch, let's say there's a 5 and a 3.5 or something, then I try to nail it. And when I nail it, I would use a balloon within the left main to circumflex at low pressure. That's what I do, just make sure that the stent doesn't protrude into the left main.
So, were you sure? I know it's kind of a little bit difficult to see from there that there's no disease in the ostium of the circumflex from the views you saw?
Yes, I think that the whole point is there's always disease.
Yeah.
There's always, if you do IVUS, if you want to check with IVUS, you're gonna fight disease. But whether it's significant, it's probably not. So I would just not complicate things in this case.
So, Professor Samat sir, do you have any comments? Quick.
I think if you have to do an osteal LAD, these lesions are usually very fibrous lesions, and you have to prepare the lesion before you put the stent. The second point I have noted is that you put a long stent, preferably a 33 or 36 millimeter, because once you put a small stent and then you find out there is a lesion distal to the, very difficult to go through the ostium stent, and in crossing that osteal lesion you may distort the struts of the proximal stent. So it's much better to put a longer stent, because it has to. Secondly, you must pull the stent up into the left main.
Okay.
And for that, if this ostium is all right, then you should not be really worried about the left main stenting, because if the left main lumen is bigger, then you can post-dilate with a very short balloon. Yes.
Any comments from the panel, from the audience? Anyone want to say anything? Dr. Mikdad, how would you do it? How would you consider doing this? Would you put a stent from left main to LAD, or just nail the ostium?
My apologies,
Okay, you didn't see that. That's okay. Okay. Okay.
Bashir, can I just make one comment
Sure,
from
please,
the last?
Please go ahead.
You see this concept about the Dr. Doshi, I think, or someone said that what's the point in opening the circumflex? If you do a crossover stent, the cell size, you'll be very lucky that the full cell side window is open towards the circumflex. You'll always have a strut or something. And the cell size maximum is 1.5 to 2 millimeter. The area is less than 2 millimeter. So we have enough studies to show that if you, final kissing does help, there is no point in, not opening the side branch. The problem is the technique. The technique should be, in my view, that the balloon should be in a healthy left circumflex. If you put a stent across it, and you want to open the side branch, just use the small tip, distal tip of the balloon to open it. Don't keep the whole balloon in the circumflex. You won't damage the circumflex, because if it's healthy. So why? Because later when you come back, you are going to have a problem. Because it will be endothelialized, and then you'll have problems in getting the device in.
See, there is a lot of debate about it, and the thing is, if you even just, there is some disease, and basically if you balloon, I know you are saying just put a nose cone there, but if it is little bit more, you are causing this as a balloon angioplasty, which may end up resulting in restenosis. I personally, and again this has been, there is no kind of a study which has shown whether you open the side branch or not open the side branch, it makes a much difference. I personally, if the flow is good, there is no significant tapering, I don't balloon it. And the reason being, again, my logic is if I put a even 2O balloon and there is a disease and inflate the balloon in that area, again I'm causing a kind of a plain old balloon angioplasty, which may end up resulting restenosis in the ostium of the circumflex. But again, I think different people do it differently.
By that debate, let me just be a bit provocative. By that debate, then why do we in DK crush, it's been clearly shown that, why don't we just put a good stent in the side branch, crush it with another stent, and not do a first case? Why is the first case, the second case more? Because of the metal within the ostium. So it's always been clearly shown that if the ostium, and the bench tests also show that if the ostium is fully open, it is much better in the long term.
Then I can understand, but here there is no metal, and it's like just few strats, and I know the cell is small, but there are other cells which are against the circ also. So it's not that going through one cell, there are multiple cells which, but again, I think that's one way of doing it, that's fine. Any other comments from anyone quickly? Muhammad Shuaib last, then we can move on to how he did it.
I think starts because, as the disease progresses and you get a disease, the surge later on, you'd have to open the struts at that point in time. Then you'd have to use,
Mike, did it?
Yeah, I think Bashir, you are right in a way,
If it all depends to me, it all depends to the patient, depends on the patient's age. If it's somebody 80-year-old, perhaps I would not open the side branch or the struts, because this may pull on for 2 years, 3 years, 4 years. But if you have a younger patient, I would always open the struts.
Just a few points. That you don't have to protrude a long way into the circumflex, just enough to open the struts, so minimize the trauma. That helps. And then if there's progression, then 2 years down the line, if you have to open the struts, you'd have to put a jugular in a balloon or whatever. So it's already open, it makes it easy for you.
Usman, what would you do? Would you open the side strut or not?
Visually, there isn't a lot of disease. If there isn't significant carinal shift or plaque shift, flow looks good, then I would leave it alone. There's data both ways, so I think it's a gray area where ultimately you have to use your best judgment.
Yes, I agree that there is no hard evidence that opening a strut is beneficial, so better to leave it.
Okay, let's move on. Please show us what you did.
Thank you. Slides, please. There is always debate whether to put more metal into the left main if it is mild disease or insignificant disease, or to nail in the ostium. What I did, I placed one wire into the distal LED, workhorse wire BMW, and the liang was pre-dilated with 215 balloon at 16 ATM. Please, video chalayega IVAS. The IVAS was done, and the area of the LED and the reference of the distal part, which was measured, that was 3.7 millimeter, and left main IVAS, which showed area of 5.2 and minimum area was 4.8. There was mild disease and the ostium of the circumflex was healthy, and one more wire was placed into the circumflex. BMW wire was placed, and the guide was used XB7 French, and the stent was placed into the ostium. There was 3.5 into 16 drug-eluting stent, and the dye was given while placing the stent. There is a flow into the circumflex, which also shows that the ostium of the LED is properly covered. NC was done with 3.75 into 12, and post NC view showed there is also still disease in the distal part, which was prior also known to me that while we did the IVAS, the mid part of the LED was also diseased, but at that time in the rec, the liang probably for me was more than 40, so preferably I did in the proximal part and then the distal part of LED. Distal part of the liang was stented with 326 drug-eluting stent, and it was post-dilated with the same NC 3.7512 from distal to proximal from 16 to 18 ATM. The whole length was post-dilated, and IVAS post PCI IVAS was done, which showed adequate result, and the area which was measured in mid part of the LED and the proximal part, that was 3.6, 3.8. These are the final views. Flow into the circumflex is adequate, and there is also, to me, angiographically as well as on the IVAS, there was no missing of the ostial part of the liang. As the patient was in ACS with raised troponin and distal vessel had sluggish flow, agrastat, bolus, and Infigan was given, and final IVAS after placement of the distal stent was not done in order to shorten the procedure. Thank you. Thank you.
Excellent case. We have all tried to do osteal lesions, and we have burnt our fingers many times. The patient comes back with roaring sort of restenosis. Now we have done LED osteal. To do osteal circumflex, I invite Osman Fahim to tell us what he did with his osteal circumflex.
For him, lecture.
Thank you and good morning and Assalamu alaikum everyone. Honored to be here in front of so many masters of cardiology and interventional cardiology. I would also like to thank Dr. Nasir Rahman. It was his case, he couldn't be here because he's on call, but I'm going to start. Could you start the slides, please? Also, my cardiology fellow, Dr. Rizwan, because the presentation crashed this morning, and since 5 a.m. he's been sending me video clips from Karachi, which we were able to put together. उसमें नीचे जाएंगे तो presentation.
Bashir, if you allow me, while Usman is preparing, can I ask Rosli a question? I've always intrigued. This drug-eluting, this drug on the DEB, you know, how does it, when you put it in the guide, what holds it and what makes it stick to the wall? So you say if it's undilated balloon and you put it and it takes, let's say, 30 seconds getting it to the, how much drug is lost or it's not? It only gets lost when the balloon expands? How is it done?
The lesion as soon as you can. Means
How soon? How soon?
Within a minute. Sirolimus eluting drug, probably you can do it about 2 minutes, but 1 minute is key. So this is where vessel preparation is good. You must make sure that the guide, the wire, and so on, and get it as soon as you can. Thanks.
Okay, so the case is a 75-year-old female who 76-year-old female who has history of left main to LAD PCI in 2015. At the time, the left main was IVUSed and it was a 5-0 vessel. It was just a straight left main to LAD PCI. No side branch ballooning was done and POT was performed. She did well for the last 6 or 7 years, then presented with unstable angina and acute decompensated systolic heart failure with a new cardiomyopathy. She's diabetic, hypertensive, AFib, has had a prior CVA, has anemia, and her creatinine was around 1.4. EF was about 30% with lateral, infralateral, and posterior hypokinesis, severe MR, and normal pulmonary artery systolic pressures. Surgical revascularization was declined because of her comorbids. So here we have her cath. You can appreciate that she has a stent in the left main. The stent wasn't brought back to the ostium since it was disease-free at the time, and I know there's a lot of debate about that. It was pretty well opposed on IVUS, well expanded, and the LAD segment of the stent looks quite good. Here you can start to appreciate that the ostium of the circumflex may not be very healthy. And I don't have images from the 2015 PCI, but the ostium of the circumflex was almost disease-free at the time. Here in the more caudal views, you can appreciate that the takeoff of the circumflex is extremely tortuous, and there's an eccentric, very tight stenosis right at the very ostium, and a relatively disease-free segment in the proximal segment. There's calcium and some residual disease at the ostium of the LAD. So I can stop here and we can hand it over to the panel. No, it wasn't. No.
Right. After Raza, who would like to comment?
2 questions. One, was the troponin positive ACS patient?
Yes, mildly positive.
Because there is some haziness in the ostium, number one. And second thing is that was she on taking dual antiplatelets?
So,
all right. So I think
do you do now?
probably there are many ways to do this, but in this case there is already a stent in this. If we don't have any imaging facility, probably the TAP tap I would do in this case.
Tap. Raiseway?
Yeah, I think you can do it either way. You just try and nail it, leave a couple of struts in the stent which is across the left main. I normally, as I say, I always use a second balloon, a soft, just massage, make sure that that thing remains open, because if you get your strut, if it slips, if you try and nail the circumflex and if it slips, then you have a problem. You need to crush it and get all this. So why not just use a 3.5 balloon at 3 to 4 atmosphere pressure in the left main to LED while you are putting the stent or placing the stent or nailing the left circumflex.
Professor Simar.
Do a delayed tap.
I think the whole coronary tree is very tortuous, and the proximal circumflex also doesn't look like a straight segment, and that this should be dealt as a left main bifurcation lesion, really. Just the way you do a
Dr. Bashir Rani?
See, I personally would consider doing even a DCB in this kind of a osteocirc lesion, because putting in 2 other stents, like it has to be like, if you do it, I think it's going to be very difficult to nail the ostium, the angle it is. You have to come into the left main, whether you do Q-lot or tap or something, but you will have to consider doing something to the LED also. So I would just balloon, adequately prep it, and if there is no significant dissection, I would consider even DCB. Maybe we can get comments from Dr. Rosli and Dr. Chen also on this, how would they do it, or would Dr. Rosli consider DCB in this kind of lesions? Can we give the mic please over there?
Consider DCB, and what you can do is you can probably cutting balloon or scoring balloon, and results are good, and then it's to be 1-to-1, and results are good, then I use a DCB.
Dr. Chen?
So use cutting balloon first and then go for DCB.
Yes.
Okay.
Dr. Chen, we want your comments too. What would you do? DK crush.
Yeah, I think it's a very challenging. Basically, I will check IVUS to see what the reason for the ISR in RAD. Finally, I think I will use DCB for RAD and then another cannula for osteal circumflex. Thank you.
Okay. Professor Suhail Aziz.
I think what I would suggest is that the angle of the circumflex is pretty acute. It's not like a T. So a tap or that is not going to work for me. And we tend not to have IVUS usage that often. So what I do is I stent left main circumflex, open the LED, and then deb the LED and do a kiss and complete it as the left main bifurcation.
Reverse culotte.
Yes. Not culotte, reversed mini crush of a sort. No. Because the LED stent is kind of right at the ostium.
Right.
Okay. Let him tell us what you do.
So I think Dr. Suhail Aziz saw my slides beforehand and knew what was going to happen, but very interesting and thoughtful comments. So this is, she had disease in the right also, which was going to be staged. So the considerations for something like this is vessel size, angulation, plaque shift, osteolarity or distal left main plaque, prior stent placement, calcification, and whether you need atherectomy or not, DCB versus stent, and I think we covered all of those factors in the discussion so far. IVUS was not done this time around, but from the previous IVUS, the LED stent was well opposed, there was underlying calcification, and the left main size was about 5 millimeter. So we adopted kind of a modified Q-lot technique for this, and I think the concern was that because of the angulation, tap may or may not work, and you may not have enough struts hanging in the left main. And there was certainly concern about the amount of disease at the ostium and proximal LED. So this balloon lesion prep was done first in the osteal circ, after which the lesion did look a little bit better. And then, sorry, I can't see the slides. A 4.0 by 18 stent was placed with a significant amount of struts hanging in the left main, more so than you would do for tap, and kind of closer to a Q-lot or a reverse or modified Q-lot, if you will.
And this is the result after the stent. We do tend to do a lot of port also when we end and before you recross the vessel, in this case the LED, we ported the proximal segment of the left main to circumflex stent to optimize it with a 5O balloon. And then a DCB or DEB was done from the left main to the LED because there was significant disease and there was some evidence for carinal shift in towards the LED ostium. The segment of the stent in the proximal circ was further optimized, and that's the result after that. Final kissing balloon angioplasty was performed. Port was done again. I don't have the images for that, unfortunately. But the ultimate result was pretty good. I think it's a tough lesion. There's significant calcium underneath the LED stent, so probably may have some issues further on. But the acute lesion with which she presented was fixed. She had a follow-up and was doing well. Her EF recovered and her MR is improved also, so there was some degree of ischemic MR in her presentation.
So for him, what happens to the, if you drug-eluted balloon before you did, and then you did a kiss? So
yes,
I'm just wondering what happens if you do a drug-eluting balloon and then you balloon after that with a normal balloon. Does the drug go away or
yeah, we
not?
try not to do it. In this case, I think there was no option because we didn't want to end with just a left main to LED DCB. I think Rosli might have a better sense for whether should we balloon after the drug-coated balloon or not, or just leave it alone.
I think that the most important thing is to try to prepare the vessel well, because I would have actually done a bit more work with the osteo LED before I put in the DCB. But even if you put the DCB first and then you use another balloon, the drug would have gone into the tissue anyway, so it doesn't really matter.
Okay, thank you very much. Great cases from Dr. Amer and Dr. Usman. I think we are a little behind, so we are going to end the session here. We'll move on to the next session. Thank you very much, all the panelists, my co-moderator, Professor Hafizullah, and thank you. Stay on our next session. Great cases in that session also, and a live case as well. Thank you very much.